a response to fluids. So does your patient need fluids? And is he going to respond to your fluids? Is your fluid going to help the patient or not help the patient? So the classic examples you see, if you have a patient, like you're in ER, you have a patient where the blood pressure is on the lower normal side and the patient has pedal edema and patient is struggling to breathe. And as a knee-jerk reaction, you wouldn't end up giving fluids here. So you would definitely think of cardiac compromise. Is it cardiac failure that I'm dealing with? And should I be really giving fluids or should I get the fluids out of the patient's body by the most useful drugs in this situation, that is diuretic? So in this situation, in the example I have given, your patient is somewhere here. And then the patient's stroke volume is on the lower side and the patient is not able to maintain the blood pressure and you wish to give diuretic and bring him back to the normal physiological range. So in other situations like the hypovolemic shock, where the patient is in shock, that is blood pressure is low, and there are various signs of hypoperfusion, and there is tachycardia. So the blood pressure is low, the patient's feet, you go with the clinical examination initially, and then you start resuscitating the patient after obtaining history and initial clinical examination. So what are the static tests that you would consider in your patient's assessment of hemodynamic status? So the static tests are the age-old tests or clinical examination points we usually depend on. Those are like the heart rate, blood pressure, collapsed vein, capillary refill time, and whatever was the previous urine output. And as we all understand, they're not very sensitive. And also, there is a lot of observer variability. You may say that the veins are collapsed. I may say that the veins are not collapsed, right? And you may say that the capillary refill time is good. I may say that the capillary refill time is prolonged. So these are all subjected to the personal observation, subjective variation. And again, if you happen to have a central venous pressure line, CVP line, or pulmonary capillary wedge pressure line, again, the absolute number is not of much use. If at all you are using, we are told classical teaching, that is, we have to look at the trends, not a single value, both with CVP and pulmonary capillary wedge pressure. Again, these are poor predictors of poor predictors in assessing the patient shock. And then chest X-ray looking for pulmonary edema. We all know how much time it would take. However quick the hospital and your system is, the chest X-ray would definitely take more than more time than you can really allow, right? And then other parameters, echo, extravascular lung volume, and also lactate values, one of lactate. So it's not the trend, you have lactate value, and even the venous oxygen saturation. So these are described as static tests, and they're not very sensitive, and they're not very specific as well. So then comes the dynamic tests. So the dynamic tests, you have tests like passive leg raising test and expiratory occlusion test, ultrasound-based tests like echocardiography, lung ultrasound, IVC ultrasound, and other parameters like systolic pressure variation, pulse pressure variation, stroke volume variation, and aortic blood flow velocity. These are dynamic tests, though not very easy to do. These are very informative, very sensitive, and they're useful if we can do them in our bedside. So passive leg rising test you can easily do, and you have to know what you have to look for. So we'll go in detail about some of these tests now. So these tests, how sensitive are they? Even some of these tests, like end expiratory occlusion test, which is done in intubated patients with respiratory hold. So it can detect a fluid drop of 5%. Okay, it's highly sensitive, right? And the other tests, which are like superior vena cava diameter variation, which is observed in transesophageal Doppler, it is said to be 36% is the threshold, right? So pulse pressure to stroke volume, pulse pressure or stroke volume variations about 12%, IVC diameter variations about 12%, and passive leg rising test about 10%, mini fluid challenge 6%, and conventional fluid challenge about 15%. So these are the thresholds for getting the positive result in when we test for the hemodynamic parameters. So we are talking about fluid challenge. So how do we do fluid challenge? So apparently Vincent and Weil, they described this fluid challenge test back in 2005, and troll approach for safely performing this fluid challenge. So this troll is what type of fluid, how soon, or what is the rate of fluid, and what are your objectives, and what are the limits for safety. So definition, there is no standardization. There are two types of fluid challenges. One is with 500 ml, which is standard fluid challenge test. And the other one is mini fluid challenge, which is again done with 100 ml of fluid. Both crystalloids and colloids can be used. And in standard fluid challenge, 500 ml of fluid is given in over 20 to 30 minutes. And it is considered positive if the cardiac index has gone up by 15%. And there are multiple approaches, like, do you have to give 500 ml? You can get away with 250 ml over a shorter period of time. And how do you assess the response to it? So multiple methods, and there is some controversy, and there is nothing like standard fluid challenge test, but we usually look for change in the blood pressure or the heart rate if we are not monitoring the cardiac output of the patient. So main drawback of this fluid challenge is you might end up overloading the patient if it is done repeatedly. So to counter this, a mini fluid challenge test, like 100 ml of fluid given over 1 minute as per description, if not 1 minute, 1 to 2 minutes, or at as short as possible time, and you look for the response. So you look for the response, and if there is a positive change of 10% or more in cardiac index, that is considered, your patient is considered fluid responsive, and you may consider giving a fluid challenge. A fluid challenge doesn't actually mean that you have to give fluid, but it tells you that the patient, there is room for more fluid if you want the blood pressure increased, or if you want to increase the blood pressure, then do you have to give fluid, or do you give inotropic support or pressure support? So then this fluid challenge test comes of use. Okay, so the disadvantage we discussed here is fluid overload if it is done more frequently, or sometimes if the patient hasn't got much cardiac reserve, they may land in pulmonary edema by the end of 500 ml itself. So what is the solution? So the solution would be you should be able to give fluid into the circulation, and if you want to remove it, if there is overload, the patient is not tolerating, and you have if you had given IV fluid, you can't take it out unless you bleed the patient if the patient's kidneys are not functioning, or you may use diuretic if the kidneys are functioning. But either thing, either of these two may not be resolving the problem created by the fluid we have added. Then comes use the patient's blood as own blood as additional volume by passively raising the leg. That is called passive leg raising test. So how do we do this? So you initially get the patient 45 degrees head up, semi-recumbent position, and then lower the patient's body to horizontal, followed by passively raising the legs to 45 degrees up. So initially you have made the patient semi-recumbent with head up, and then horizontal position, and then on the opposite side you're increasing the legs of the elevating the legs of the patient by 45 degrees. And the maximal effect here occurs at 30 to 90 seconds. And if the patient's stroke volume is increased by 10%, it is considered that your patient is fluid responsive. Or you can use a surrogate such as pulse pressure if we are using just an arterial line and not using cardiac output monitor. This change would give you an indication that your patient would respond to additional fluid you're going to give. And the response, how do you see? If the stroke volume 9% increase, 86% sensitivity and 90% specificity, 10% increase in pulse pressure, 79% sensitivity and 85% specificity. Okay. So also if your patient is on anesthesia table, or you have an ETCO2 monitor in your ICU, and if you're doing passive leg raising test and there is 5% increase in the ETCO2, that again would tell you that the patient would be responsive to the additional fluid. So we had gone through various clinical situations, and then you assess the severity of the patient's shock.
Doctor, sorry to interrupt in between.
Yeah.
We just have 5 minutes, doctor. We'll try to wrap up the session a bit earlier if possible.
Yeah, sure. Okay. So we have gone through various situations, and now, so you assess the patient, and then you assess the patient's severity, and then fluid responsive or not, and then you have to look for the shock so that you can, along with resuscitation, you can treat the shock, definitive treatment of the shock. In general, the shock can be hypovolemic, septic, or because of cardiovascular problems, or it can be secondary to other systemic problems, and it can maybe patient in metabolic acidosis, hyperlactatemia, and then responding hypotension. So hypovolemia, it can be either because of trauma and blood loss, or it can be other fluid losses like GI, both upper and lower GI losses. And sepsis, we all know there is relative hypovolemia along, and then it's not just hypovolemia, also there is myocardial depression in sepsis. So both distributive failure and the pump failure. And in cardiovascular shock, you have myocardial infarction, poor pumping capacity of the heart, and secondary to other diseases as I described before. So you take clear or brief clinical history depending on the situation, and you examine the patient's anatomical examination, head to toe, and look for the bleeding points. And you take the help of bedside tools, both clinical, your monitors, your ventilator, your ultrasound machine, and the urine output if you have longer time, or you can retrospectively see the urine output. And then the laboratory parameters like how are the electrolytes, and how are the hemoglobin and packed cell volume, and how are the lactates, how are the bicarbonates. These all would help you to assess the patient's perfusion, tissue perfusion, and see if the patient is stable hemodynamically or not.